Alright, so this section we're going to go over some adnergic antagonists, and we're also going to go over some parasympatholytics. Parasympatholytics. It's a mouthful. Alright, so when we're talking about the adrenergic blocking drugs, or the antagonists, okay, these are a unique class of drugs, and they can be receptor specific or they may be just general. But you're primarily going to be looking at your alpha and your beta adrenergic blocking drugs. So with your alpha blockers, typically these are going to compete with your norepinephrine to bind to the alpha receptor sites. If they are blocked and that norepinephrine does not bind to it, it's going to prevent that norepinephrine from producing a sympathetic response. So what happens is that normal sympathetic activity is decreased in the organs that have the alpha receptors. And since your major alpha thing is the blood vessels, basically what's going to happen is you're going to have a vasodilatory effect and lowering of the blood pressure. So with that, most of your alpha blockers are actually going to be used in the treatment of hypertension. All right. Now, with your alpha blockers, you may also see it used in like glaucoma, or you may see it in the BPH, the benign prostatic hyperplasia. And what happens there is it actually blocks and relaxes the smooth muscle of the ureters, which is going to help improve your urinary output. Right? When you have the alpha blockade and the sympathetic activity is blocked, then your effects are going to be very similar to an increase in that parasympathetic activity in the organs that have been blocked. Usually, these effects are going to be similar to stimulating the other side, so the sympathetic system. So you may see constriction of the pupils, meiosis, the MIOSIS. You may see nasal congestion, increased GI activity. Those are all fairly commonly experienced after your alpha blockers are administered. You also may see some compensatory reflex tachycardia if that blood pressure is significantly lowered, just as if your heart's like, oh crap, what happened? Boom, and it's going to up that rate to try to maintain initially. Right. So with that, some of your patients, if they've recently taken alpha blockers, they may actually have a little bit of orthostatic hypotension or even a full-on syncope or fainting episode. So be careful with that. Now, as far as your beta adrenergic, this is the one we're going to focus on the most because this is the one that you are more apt to actually give in the field. All right. So with this, with your beta blockers, they're going to bind to whatever beta adrenergic receptor site they are, and they're going to antagonize the beta effects of epi and norepinephrine. This is going to be used for hypertension, angina, some arrhythmias, anything where you have excessive amounts of your epi or norepi being released. Now, most of these are going to work primarily on beta 1, the heart. Okay, that's going to be one of the most clinical important uses of it. It's to decrease that activity in the heart. It's going to decrease the heart rate, decrease the force of contraction, and decrease that impulse conduction throughout the heart. There was really not any specific reason or therapeutic reason or indication to give to block a beta 2 receptor because that's going to cause bronchoconstriction, and we don't want that typically. That's usually not going to be a good thing. All right, so most of these are going to be either, like I said, selective or non-selective. At therapeutic doses, the selective beta blockers are only going to block your beta 1. Now, at the higher dosages, they may start to block beta 2, even though they are selective for beta 1. Propranolol is one example, and it's actually going to block both beta 1 and beta 2. And there's several other ones that will cause these similar pharmacological effects as well. Propranolol is one that is given fairly often as well because it is lipid soluble, which means it will pass into the brain fairly easily where it can cause its effects. And some of those, it might be central nervous system sedation, depression, decreased sympathetic activity, which actually kind of helps lower the blood pressure as well. Now, some of your other ones, atenolol, things like that, are water soluble, and they're not going to pass into the brain, and they're going to be excreted throughout the urine. Labetalol goes, okay? It is a non-selective beta adrenergic antagonist, which means it's going to block your beta 1 and beta 2, and it's also selective for alpha 1, so this is going to be used a lot of times pre-hospitally for reducing that blood pressure. And it's going to do this by decreasing the cardiac output through the beta 1 properties and causing a peripheral vasodilation your alpha-1 properties. Your onset's pretty fast, couple of minutes there. Peak effects, 5 to 15 minutes. Duration's 2 to 4 hours, and the half-life's 3 to 8 hours. So it is a good choice usually for acute management of a hypertensive crisis when you have signs of end organ changes or failure there. So indications: acute management of hypertensive crisis with your end organ damage. Ultramail status, chest pain, renal failure, severe headache, things like that. Your contraindications: bronchial asthma, congestive heart failure, a heart block, bradycardia, and cardiogenic shock. All of which makes sense because if the heart's already failing, we don't want to slow it down and make it work even harder. All right. So your dosing, you've actually got two kind of accepted methods that you can give labetalol when you're talking about treating the hypertensive crisis. So dose 1, you can give 20 milligrams slow, and I mean slow, IV injection over about 2 minutes. And then make sure that you assess your blood pressure, supine blood pressure, before the injection at 5 minutes and 10 minutes after the injection, because you can have a substantial reduction in that blood pressure. All right. After this, you can give additional 20 milligrams every 10 minutes until desired supine blood pressure is achieved or 300 milligrams has been given. All right. Why do you want to do supine? Because, like we said, they may have a syncopal episode. They may have orthostatic hypotension, so you don't want them standing up or sitting up. You want them going ahead and laying down. For your dose 2, right, you can do a drip. So you're going to take 500 milligrams and you're going to add it to a 250 bag of D5W. This is going to give you a concentration of 1 milligram per milliliter. And then we're going to give it 2 milligrams per minute to a max dose of 300 milligrams, all right, and then continuously monitor the blood pressure. Most everywhere I have worked or that I know of, they're going to give just a straight bolus at, usually 20 milligrams, 10 milligrams, something like that. They're going to give a straight amount and then reassess. So depending on where you are, what your agency has, what they prefer, will be determine what you do. But there are two options there that you can use. Now, as far as your precautions, as with all of your beta blockers, monitor your patient continuously, okay? Be alert for signs of congestive heart failure, bradycardia, heart blocks, bronchospasms, things like that. So listen to their lung sounds, all right? Your interactions, do not give it to somebody who has received IV calcium channel blockers, all right? You will hurt them. And if they are taking any kind of hypertensive agent, be very careful and monitor very cautiously. And if you're not sure, talk to your med control, because there are some interactions that can occur. You can cause a precipitous drop in their blood pressure. And the whole point of what we're trying to do is help them, not kill them. So there's that. As far as side effects, same thing as a lot of your other beta blockers, your other things that are going to slow the heart rate. You could have bradycardia, hypotension, lethargy, heart failure, dyspnea, wheezing, weakness. So all things to be alert and aware. So for your parasympatholytic medications, basically this is going to be a medication that's going to inhibit the parasympathetic nervous system. You may see it called an anticholinergic because the parasympathetic system is also called the cholinergic nervous system. So anticholinergics is what we're looking at here, and they're going to play a pretty big role in homeostasis, because you have to have something to bring everything back down. Sympathetic's going to jack everything up, parasympathetic's going to bring it back down. So these are really good when that sympathetic nervous system's kind of getting away from you. All right. They have a lot of different pharmacological actions. They're going to affect the cardiovascular system. When we block acetylcholine is the main neurotransmitter for the parasympathetic system. So what we're looking at is changing how the acetylcholine is binding to those cholinergic receptor sites. Okay, a couple of different receptor sites. You've got your muscarinic, your nicotinic. If you need some refreshing on that, go back to that module. There's a module or a video about the receptor sites and what they do. So we're looking at blocking the effects of acetylcholine on these receptor sites. So in the cardiovascular system, it's going to block the activity of the vagus nerve on the heart. So you're going to have an increase in the heart rate. All right, so this is why we may give atropine for bradycardia. In the respiratory system, acetylcholine is going to increase the secretions of the respiratory tract and cause bronchoconstriction. So we give an anticholinergic medication to open up the airway a little bit and to inhibit those secretions so we're not blocking those airways. In the GI tract, your anticholinergic drugs are going to reduce your saliva and GI secretions. They're going to decrease the motility of the GI tract. All right. For the genitourinary systems, it's going to inhibit your urinary peristalsis, so that way you're not peeing as much. The main nervous system, it will cause kind of a depressant effect and may result in some drowsiness, sedation, things like that. And it will also cause a dilation of the pupils. And if you actually go to the eye doctor or something, they dilate your eyes to be able to look in there during your eye exam. That's one of the drugs the drug they put in there. The drops are an anticholinergic. I can't even say it now. It's one of those drugs. And what it's going to do is it's going to dilate your pupils so they can see in there a little bit better. All right, you never ever want to give that to a patient with glaucoma because it's going to increase that intraocular pressure, and that's not good for somebody with glaucoma. So our main drug here that we're looking at, this was going to be atropine. Okay, it is an anticholinergic, and it is derived from the belladonna plant, which is kind of cool. Very toxic. Don't eat it. Your medication of choice for your hemodynamically significant bradycardia. So in other words, their heartbeats is too slow, and it's causing them problems. So we need to fix it. Okay, it's going to act by blocking that acetylcholine receptor site, and it's going to inhibit that parasympathetic stimulation. It's also used in your organophosphate poisonings along with peroxidine, but for here we're talking about primarily for the bradycardia. So the onset is pretty much immediate. Okay, the IV is there. Your peak effect is a couple of minutes, duration is a couple of hours. So your indications, that bradycardia, organophosphate poisonings. It is no longer, for a while it was, but it is no longer recommended in the routine treatment of cardiac arrest for PEA and asystole. It used to be part of the algorithm. It's not. Will it come back? Maybe at some point, but right now it's not. Contraindications. In the emergency setting, there are none. All right, so for your dosages, if it is a hemodynamically significant bradycardia, 0.5 milligram, 0.5 milligrams IV bolus every 3 to 5 minutes, max of 3 milligrams. If it is organophosphate poisoning, you're going to start with 1 milligram and you're going to keep giving it and you're going to keep giving it and you're going to keep giving it. You're probably going to run out of atropine on the ambulance unless you just happen to be in the shadow of the hospital when you get there. All right, so you're going to give a substantial quantity of atropine when we're talking about organophosphate poisoning. Precautions. All right, if it is a bradycardia that is associated with a high degree heart block, a second degree, type 2, or a third degree, it can actually worsen that bradycardia. All right, make sure that you have pacing available. And like I said, you don't want to give that, or you don't want to exceed that maximum dose there, except for in the setting of the organophosphate poisoning, because you can have some pretty nasty side effects. Okay, blurred vision, dilated pupils, which is why it causes the blurred vision. But anyways, dry mouth, tachycardia, drowsiness, inhibited GI tract. So lots of problems here. Confusion, it's no good. Tachycardia can happen. As far as interactions, there really are none in the pre-hospital setting.